My talk will be about the principles of treatment of massive rotator cuff repair. Actually, when we're facing a case of massive rotator cuff tear, we have too many questions like who has pain? Why do they have pain and or weakness? And when should we operate? What operation should we do? And what are the goals of the surgery? And which method of treatment is correct? Actually, it's a big dilemma. We have to know that these patients usually come with different presentation like the following one, either pseudo-paralysis with or without pain, weakness with or without pain. Sometimes they come with a very good function, strength, and this may be associated with pain or even without pain. Sometimes they come with a failed prior surgery with associated pathology, such as deltoid injuries. Before going to furthermore, we have to define the problem and we have to differentiate between massive and irreparable tears. By definition, North American definition by Cofield, he said that a massive tear, this is a tear which exceeds 5 centimeters in diameters. And as regard the European definition by Gerber, he said, when we have more than 2 tendons torn after debridement, this is a massive tear. Actually, 80% of these tears are posterior superior, meaning that they are supraspinatus and infraspinatus tears. And while about 5% they are anterosuperior, subscap, supraspinatus, and infraspinatus. There are certain key factors that we should consider when treating such cases, like quality of tendon tissue, muscle quality or quantity, meaning atrophy and fatty degeneration, the quality of bone, neurogenic cause of pain or weakness, and of course, the surgeon skill, which is very, very important. Gerber and others, they mentioned that the tendons which tear are never normal. And delamination usually occurs, and this affects the technique. Tendon quality correlates with muscle quantity and quality. So if you look at this video, this is an arthroscopic view of intra-articular. You can see the probe is going between 2 layers. This is the superficial layer and the deep layer. And if we go to the subacromial space, you can see the grasper is holding the deep layer. So there is delamination. This is very important when you deal with a massive tear because the deep layer should be repaired. And many of us don't repair the deep layer and usually repair only the superficial layer. When we come to the muscle quality and quantity, we have to know that muscle atrophy is reversible. And GP Warner just graded muscle atrophy into different grades, as you can see in the photo. But fatty infiltration is irreversible. As you can see on the left side, this is a normal muscle in patient with cuff tear. But on the right side, we can see and notice the fatty infiltration in patient with cuff tear. So fatty infiltration is very important, and Guterrier just classified this fatty infiltration into different stages, and according to the stage, this tear can be repaired or can be irreparable. When we come to the bone quality or osteopenia, so on the left, you can see a recent tendon tear, and on the right, a case of chronic tendon tear. So chronic tears usually affect the bone quality and the anchor fixation. Usually you put the anchor in this area, and you can just see the amount of bone in this area in chronic tendon tear that may affect the fixation and the repair. Next point is the neurogenic cause of pain. The suprascapular nerve dysfunction with massive rotator cuff tear is not a rare problem. And this has been proven by Burke and GP Warner, who just made an EMG study on 26 massive rotator cuff tear. And they found that about 27% of the cases had a suprascapular nerve dysfunction. So this is due to traction on the nerve by that retracted tendon. And when we do arthroscopic partial repair of the posterior cuff, this usually will result in clinical improvement and recovery of the suprascapular nerve dysfunction. We can see that there are certain relevant factors in case of irreparable cuff tear. Of course, we should take into consideration the smoking history. And when we examine the patient, usually has mild weakness, hornblower sign, and external rotation lag sign. X-ray will show a static proximal migration of the humeral head, as you can see. And of course, in the MRI will show us a marked and significant fatty infiltration. So if we face this situation, this is an irreparable rotator cuff tear, and we shouldn't go and try to repair it because it's going to be a failure. So what are the options that we have in case of irreparable rotator cuff tear? Well, we can do debridement and biceps tenotomy. We may do partial repair, aiming to just relieve the tension on the suprascapular nerve and improving the function and the pain of the patient. Or we can just attack the suprascapular nerve by doing a decompression and cutting the suprascapular ligament. Of course, latissimus dorsi tendon transfer and PIC major tendon transfer, as mentioned before by my colleague. And at last, one of the options is the reverse prothesis. I'm going to show you an interesting case. This is a 52-year-old man who had a chronic pain, which was about 8 out of 10. He couldn't sleep and he felt weakness. And he stopped playing golf because of that. As you can see, the MRI, there is a severe retraction and tear of the supraspinatus and infraspinatus tendon. And this was his MRI. When we did an EMG for this patient, there was that conclusion was there is evidence of axonal pathology affecting the branches of the left suprascapular nerve. So he had a suprascapular nerve problem. And when we just try to do a partial repair of this patient, I'm sorry, the video is not working. So we did a partial repair for this patient, and surprisingly, the patient came later and he was improved. And when we redid the EMG, the impression was there has been improvements in the left infraspinatus muscle function since the last study. So actually there was improvement. When we come to the latissimus dorsi transfer, the patient has to have a weakness and MRI, which shows a severe fatty infiltration. And of course, external rotation leg or hornblower test. Intact subscapularis is very, very important. And of course, the deltoid should be intact. And this is just an image showing how we do it. A video that I'm going to skip because of the time. Same thing for the subscapularis. If we have irreparable anterosuperior cuff, sorry, there's a problem with my presentation. So when we have an irreparable anterosuperior cuff, the same thing when we do an MRI, we can see a significant fatty infiltration of the subscap and extreme or excessive external rotation under when we examine the patient under anesthesia. So we may do a PIC major transfer, and there are several techniques mentioned in the literature, either the Rockway technique, Resch, or Warner technique. As you can see in these images, how we do the PIC major transfer. So, and if we have a pseudoparalysis with pain, as you can see with this patient, and with an external rotation lag and hornblower sign, as we can see, so the only solution is to do a reverse shoulder arthroplasty to regain the function and improvement. And if there is an external rotation problem, we may do a latissimus dorsi transfer with that, as described by Pascal Boileau. So, in case of irreparable rotator cuff tear, we have different options. Either we do scope debridement and biceps tenotomy, or in case of suprascapular nerve dysfunction, we may do partial repair and suprascapular nerve decompression. Or we may do latissimus dorsi transfer or PEC major transfer according to the torn tendon. And lastly, the reverse shoulder arthroplasty, which may be very helpful in such a case. So for conclusion, the patient problem should be well determined in order to choose the best treatment option, because if you fail to plan, so you plan to fail. Thank you very much.